Welcome, everybody, to this session. I'm Shuaib. I'm founder and CEO of Newton's Tree. The title of the session is Enterprise AI at Telehealth with Newton's Tree. And joining me on stage today is Steve. Steve, I'm going to hand over to you to introduce yourself a little bit, and then we'll share with the folks the good news that we have.
Great. Steve West, Managing Director of at Tanner Health, but specifically our Healthline Ventures arm. We're a corporate venture arm for a $1 billion net patient revenue health system. And we're, incredibly excited to be, partnering with companies and investing in companies that are on the forefront of this AI revolution. And without kind of taking about, a little bit of the surprise out of it, really excited to be working with Harris and Newton's Tree.
Fantastic. Thanks, Steve. So for those of you who are in the partner program on the UK stage earlier in the conference, we were proud to announce the partnership between Tanner Health and Healthline Ventures and Newton's Tree, a British company making headway in the US to advance responsible AI adoption and improving patient outcomes. I'm going to go into a little bit about what that means, but I'd love to hear first from Steve what that means for Tanner Health and the local population.
Yeah, for us, we've been looking at AI tools for a long time. And at this point, the issue that we run into with AI is almost the opposite of what happens with general SaaS programs, right? It takes a long time to procure those, to implement those, everything. We try to see a lot of business value, but the business value is not really changing in the same way that AI models are constantly changing. They're constantly updating. We're getting new information there. And so we need to be very nimble in terms of how we assess these types of models coming into our organization. And our IT team can't keep up, right? And so when we were looking for a partner here, we wanted to understand how can we be a lot more agile in the evaluation process. If we know there are going to be multiple modules in lung nodule identification, how do we compare them side by side in the way that we do it on a SaaS type structure? And then on an ongoing basis, how do we know that the model is continuing to perform? Because we do that all the time for general software where we try to say, well, is anybody using it anymore? But models sometimes slip into the background. And so for us, we just needed much more of an infrastructure around this. We weren't seeing anybody else doing this actually within the US that we found sufficient. And that's why we had to go abroad to Great Britain to find folks that were thinking about this at a different level.
Fantastic. Thanks, Steve. And just on that point, not only are we from Britain, but a lot of the team at Newton's Tree, including myself, are from the health system itself. So I was fortunate enough to build the NHS's first dedicated AI team. And a decade of that experience has boiled down into the Newton's Tree platform and capability, where we help health systems like Tanner and others throughout that entire life cycle of adoption. Just like you would have with SaaS technologies, one of the first challenges that health systems have is, to be honest, the real vendor exhaustion that you're feeling. Even just at this event, there are so many companies with AI in their name, it's very difficult to understand the real from the snake oil. And also the very real variation in performance you get in different populations, right? California is not Georgia, and Georgia is not the UK. And if you care about responsible AI adoption, it's important that we're able to validate some of these products in local populations. Steve, do you want to talk a bit about the local population in Georgia?
Yeah. The local population in Georgia is very diverse, right? But we're primarily suburban, mostly rural population, right? So that's going to be very different than what you're seeing in the Pacific Northwest and the Northeast. Our CHF rates are going to be a lot higher. We eat a lot of brown food in the Southeast. But so we need to understand that these models work on our particular populations. And the reality is that we are clinicians, we are administrators, we are not model evaluators. And so you do this in so many other different parts of it, where if you need help in your revenue cycle, you go to the experts on that to optimize the process. And, for us, you can't test business value of models in the same way when it's essentially there's non-published academic research or, whatever their weights of their models are we can't assess those side by side and trust what those folks are saying on a consistent basis.
Fantastic. And Steve, maybe I could ask you to touch a bit about also the procurement process value for money question when you can test multiple products head to head.
Yeah. I mean, for us, then it becomes an issue of, how do we look at what's going to be the most viable model, right? Then we start looking at the economics a little bit earlier, right? It changes things and it puts it on its head where we can test, we can evaluate before we make the purchase decision, as opposed to right now, you have to sign the contract before you get to see any of the real results on the pilot. And that changes the way we think about making a business case to our organization, because we already saw ROI or impact on this prior to signing a 3-year contract.
Exactly. And then, Steve, you also touched around, IT resourcing. I mean, particularly from where we come from in the National Health Service, no IT department has spare resources. You're constantly fighting a prioritization battle. Can you add a bit of color from your perspective, Steve, around the value proposition around speed to deployment and the resource constraints?
Yeah, so we're constantly looking at resource constraints on our end. I've got folks on my team that are managing that consistently with all the Epic upgrades, source systems, legacy systems. Maintenance is never taken into account on an ongoing basis. Before Newton's Tree, on average, it takes us about 3 to 4 months to implement an AI system. And Tanner is very quick. We're a very quick organization, very little bureaucracy. It still takes a long time because of the number of integrations that need to occur, how we're managing our cloud deployments elsewhere. Newton's Tree it simplifies that pretty significantly.
Yeah, it's funny you use that number, 3 to 4 months, but that is very fast in the health system terms. It's very common for health systems to post-contracting take, particularly in the UK, up to a year to deploy AI technology. One of our first customers in the UK, Leeds Teaching Hospital, had a signed contract with the AI vendor, and 14 months later hadn't deployed the technology. And we were able to deploy our platform and that technology in 4 weeks. And now, once our platform is in, you're now able to theoretically deploy technologies in about 30 minutes. That's how quick things can go. And that's where the real magic happens. And when you make deployment and integration that easy, you begin to change the dynamics and the behavior patterns of a health system and then the partners that you deal with. With my background at St. Thomas's in central London, it was almost like a big political battle to get a technology deployed. And eventually these deployments became too big to fail, right? Because you pulled all sorts of favors from the CIO and the information security team to get it over the line. Now the model has to work. Even if it's got disappointing performance, you now have to find a way to make it work. And that's not a great position for a health system to be in.
You never want to create a situation where there's a lot more scrutiny around how you got something through the organization, right? So creating these monolithic sales processes that take a long time to get through, ultimately that gets assessed later on by your IT team. I work with our IT team pretty closely, and they say, well, this last one that I took a flyer on with you, and, this was a 12-month implementation and it ended up not working. Why am I going to trust you on this next round? So you have to have the right accountability structure there too. And Newton's Tree provides a lot more data on that end.
Fantastic. And then the funny thing is that the fun only starts once you've deployed the technology. And a lot of health systems now are facing the challenge around governance of these technologies. So you're like, okay, great. I've managed to deploy an AVT, revenue cycle management, radiology, histopathology algorithms. And now it's sort of 12 months down the line. The clinical champion maybe has moved on, right? Nobody's talking about the project anymore, but the CFO still has a bill on their plate. CIO still has services to maintain. And then the question becomes, is this still delivering value for money? Is it still safe and effective? So as Newton's Tree, we're health system folk, and we've invested a lot of R&D effort in this monitoring phase. Our solution to this is called FAMOUS, which stands for the Federated AI Monitoring Service. And it's actually listed on the UK government's list of approved AI assurance techniques. Steve, that was one of the things that really hooked you at the beginning. Do you want to tell us a bit more about some of the challenges that you face in the post-deployment regime and how you think we might be able to help tackle it?
So I even think about it not even just at the post-deployment standpoint. I think about it up front on the contracting side. So a majority of AI vendors that we are working with will not put in any sort of SLAs around model quality, right? That's crazy for most health systems to take on, right? Because we do with SLAs all the time for uptime on the cloud. That was a big part of the on-prem to cloud transition, is you had to have the same level of uptime in the cloud as you had on-prem. And so people put it in their contracts as a result, right? People are not willing to provide, monitoring around the model quality. They say, well, report on the number of physicians that are satisfied with this ambient listening solution, but they're not going to tell you the number of summaries that were wrong, right? That becomes a real pain point for us, because ultimately, when it's not contracted for, we bear the brunt of the liability. And that's going to be a bigger issue, down the line. We don't have the infrastructure to do it today. And that's what really hooked us about, Newton Street. We need to be able to do maintenance on, our AI models in the same way that we do it on data security.
Yeah, exactly. And that's the thing that I like to impress upon people. People often say, why do we have to do all this stuff with AI technology? We actually do it for everything else already, right? Quality assurance, audit, managing supplies and services. That's bread and butter for delivering a healthcare system and health operations. We just haven't been doing it with AI because we've been kind of swept away by the shininess and the novelty of the technology. And we've forgotten sort of the principles of good governance. And now it's bringing back. And so a lot of health systems, including Tanner, are standing up governance committees, which I think is an important structure. The challenge then becomes what do you discuss? Like, what's on the agenda and what is the material?
Yeah, I mean, a lot of it right now is, should we allow access to ChatGPT for our folks? What types of information are being put into those prompts and elsewhere? That's not necessarily getting to the real use of AI right now. That's a smokescreen for the broader pieces in radiology or other types of departments that it's been being deployed right now. It's in use and we don't really have an answer. So that's why we look outside of what it is, and we want to be agile about incorporating best practice recommendations on that side, because this industry is evolving so much that it's impossible for one system to digest all of the changes that are occurring.
Yeah, exactly. And the slides are deciding to auto skip, and I'm not sure why, so I'm going to be like jumping back and forth. The final thing I wanted to touch on is, again, with health systems that are becoming relatively mature in their AI adoption journey, what you really want to deliver is a differentiated service for your patients, right? Why would a patient want to be treated at Tanner or by Tanner Health? How can you deliver a different quality of service? And the really exciting thing is today, and this show is testament to that, sorry for the skipping, is if we imagine a futuristic patient pathway where every touch point from first presentation where Jane is calling her primary care physician, all the way through diagnostics, therapy, post-discharge monitoring, there's AI that can help all throughout that journey. And that AI is on the shop floor today. But we are not adopting AI in a way that transforms pathways. And actually, that's where it becomes really exciting, and you can deliver a different quality of service and a higher quality of service. Steve, do you want to touch a little bit about how the fact that you're working with so many vendors, you can now begin to start to stitch them together?
Yeah. So one of the ways we're looking at it is on kind of two different vectors.
Yeah.
So, and this is on both the innovation investment side as well as on the deployment side. One side is, how do we actually augment the intelligence of physicians, right? So that they're either seeing things that are not easily available via the naked eye, right? Or you're getting the average physician up to a superior physician just consistently. One vector there. The other is, how do you make one person do the work of 10, right? It's working at the top of your license, all of those types of things. When you get both simultaneously, it's really a reimagination of your entire operational infrastructure. But to do that, sometimes it's not one tool that can do it all. And any of these vendors out here, some of them get close, right? But a lot of times you're going to have to stitch them together. But that means that you're going to need some methodology for making sense of that. and ensuring that there's monitoring of the outcomes and the outputs, right, throughout the flow of the patient journey. The patient looks at it as improving their experience over time, right? But for you need to make sure that that is seamless as much as possible, even though all of these tools are not necessarily interoperable.
Yeah, exactly. And so you've already touched on a lot of the challenges there. So there's the infrastructure and the data piece to make sure that that seamless integration happens. There's also an accountability thing. It's very common for example, oncology wanting to deploy something that helps with diagnosis of cancer, and then radiology having to bear the cost of that. And then it becomes confused around who's accountable, which budget line is this coming out of, and it requires a bit more joined up thinking from the exec team ultimately, and from the chief medical officer. And then ultimately you need a much more mature enterprise, and that this sort of siloed way of practicing medicine becomes a bit of a hindrance around this sort of redesign. And the thing that we wanted to focus on at Newton's Trees, we didn't want the infrastructure to be the barrier. For so long, whenever you wanted to innovate within the hospital, you hit across these infrastructure barriers. Oh, I can't do this because my EMR doesn't let me do it. I can't do this because my PACS vendor doesn't let me do this. And I think that's a real unfortunate series of events that have happened. But AI allows us to rewrite the rule book. And so one of the things that Newton's Tree is actively working on with health system partners, particularly in the UK, is can we transform initially the orthopedic pathway end to end, from presentation to the primary care physician or physio, referral to diagnostics, pre-op assessment, operational intelligence, and then post-discharge follow-up and long-term monitoring. And some of these vendors are here today. VitVO is on the UK Department of Trade stand just over there. And what we want to do with health systems like Tanner is remove some of that complexity and risk and achieve a qualitative different experience for your patients.
Yeah, the sooner we can get to some of these platforms where it's all stratified, we understand the information here, the sooner we can focus on the core, which is patient care and patient experience.
Yeah, and ultimately at Newton's Tree, we want to be vendor neutral. We're friends with OPSI and VitVO, but really we want to give the health system the flexibility and choice to work with whatever AI vendor that works best for their patients and their population and their physicians.
That's what's, I think, going to be different. And, that's one of the things that Harris and I, we have great philosophical discussions about, the differences between the UK market and the US market. The procurement process in the UK, it creates a little bit more, ownership over that. Whereas American health systems, we want the freedom to be able to pick all of these. And so we need a platform that can enable that freedom in a way that scales with us and scales with our process that others may not be able to offer.
Yeah. And that's why it's the land of the free. And then I'm just going to finish with this final slide. Feel free to take a photo of the QR code. We published this week our white paper on the future of care, how we as health system and AI folks think AI is going to genuinely transform the delivery of care pathways. So AI-driven clinical pathways for better outcomes. Thanks so much, Steve, for joining me today. And thank you guys in the audience. Happy to continue the conversation after this session. We also have a booth just right there, 4260. Thanks, everybody.